Hi, welcome to today's episode of OBGYnugget. We are back after quite some time with a topic on which I have made two videos earlier, but something that I'm going to be speaking differently this time. I'm going to be approaching the algorithm of Rh negative pregnancy and how do we manage them. It is going to be a brief discussion. It is going to be a brief discussion on how do we manage each type of complication, each result, and how do we in fact go ahead whenever we have a patient with Rh negative pregnancy in our OPD. So it is going to be a straightforward discussion. There is not going to be much discussion on the peripheral aspects of it, on the theory of it. It is all going to be about how do you manage this patient whenever she comes to your clinic. So the first moment of contact whenever a female is coming to you is going to be at the point of booking. And by booking, I mean that she is getting antenatally registered with you. So whenever she gets antenatally registered with you, I don't know what is the blood group of that pregnancy, of that female, of that pregnant female. So all I ask her first of all is to do a blood group. If it is turning out to be positive, then there is nothing different that I'd be doing. I'll be following her up as a usual routine antenatal patient and ANC patient. But the problem arises if it comes out to be negative. Then I ask that female, if it is negative, then I would ask her to please do her husband's blood group as well. Over here, if the husband's blood group comes to be negative, then the wife is negative, husband is negative, and there are no antigens from either of them, so there is no problem at all. So it again becomes a low risk pregnancy. But the problem starts, as is the case in most of the patients with wives having Rh negative blood group, if the husband turns out to be a positive blood group patient or a person. So this means that the husband is having RBCs, erythrocytes, which has an Rh antigen that is present on them. So whenever the sperm of the husband and the ovum from the female are going to meet and they are going to form an embryo and the baby is going to be formed, that baby shall have even the paternal Rh antigen that is coming, and the moment the fetal RBC, if it contains the paternal if it contains the paternal Rh antigen, if it goes into the maternal circulation, if it comes in contact with the maternal blood, then there is going to be antibody, and an antibody response. There are going to be antibodies that are going to be formed. Now these antibodies are going to be of the IgM type in the first pregnancy. After 6-7 months, these antibodies will become IgG, but fortunately by then the baby would have been delivered. The unfortunate side of it, it's going to start building whenever she conceives the next time. When now the current baby, I mean the second baby in that pregnancy is going to be affected by those cells which are already made. There are going to be memory cells that are present in that female. Those memory cells are now going to make IgG, and IgG can cross the placenta. It is going to cross the placenta in the second fetus and it is going to eat up the fetal RBCs. So coming back, once she comes to me and at the point of booking, I get to know that her blood group is negative and the husband's blood group is positive, then either immediately or ideally at 12 weeks, I shall be asking her to do a test called as ICT. ICT is indirect Coombs test. This indirect Coombs test is going to just detect if there are any antibodies that are present inside that female's blood. When I do the ICT, obviously I am going to have two possible reports. Also remember a thing, that do not discount the fact that if she is a primigravida, she will not have any chance or any risk of alloimmunization. Alloimmunization means that an antigen that is present in a human species but in a different human has entered a person's body and now it is causing a response, an immune response to it. If it would have been a self antigen that is eliciting a response in my own body, it would have been called as autoimmunity. So over here we are calling it alloimmunity or alloimmunization because it is coming from the father. It is another individual but of the human race itself. So I'm going to have two possibilities, and yes, I was talking about primigravida. So in primigravidas, do not discount the fact that just because it's a first pregnancy, there is no chance that she will be alloimmunized. Remember, there is something called as a grandmother effect in terms of Rh negative pregnancies, wherein that female who's pregnant now, when she was herself inside her mother's womb, at that point of time, the mother's antigen of positive blood group, if the mother was Rh positive, those cells entered that female's blood when she was inside the womb of her own mother, the same female who is now going to be a grandmother when this fetus is delivered. So at that point, alloimmunization can occur. It's a very theoretical concept. Rather than theoretical, it's a very rare concept, but it can be possible also if this female has at any point of her life received exchange transfusion, plasmapheresis or platelets, which are often going to have positive cells in it. In these scenarios also there is a chance that she might already be sensitized to it. So just because she's a primary gravid doesn't give you the liberty to discount all these investigations. So I'm going to have two possibilities. The first possibility is going to be the best possibility, that is the ICT comes to be negative, and the second one is going to be if it comes to be positive. Now talking about the best outcome, that is negative, what do I do if it is negative? I can be relaxed. I just wait till 28 weeks, and at 28 weeks of gestation I repeat the same test, ICT. Now you would ask me as to why do I need to repeat it at 28 weeks of gestation. Now there is a chart, there is a curve that is given in Williams which shows that if I'm going to be taking these two axes, on this axis there is incidence, and in this axis is the amount of feto-maternal hemorrhage in ml. ml is milliliter. Now this chart shows that across first trimester, second trimester, third trimester and around the time of delivery, the amount of feto-maternal hemorrhage that occurs is only going to keep on increasing. So the incidence increases and the amount of feto-maternal hemorrhage that is occurring also increases. This shows that a significant amount of feto-maternal hemorrhage occurs especially at third trimester and around the time of delivery. Hence, that test at 28 weeks is very essential because there might have been some event that has led to isoimmunization, sensitization between 12 to 28 weeks, and hence that 28 weeks wala point is very important. There are several reasons why this feto-maternal hemorrhage can occur. A few of them being if the female had threatened abortion in first trimester and she had heavy bleeding, but fortunately she was able to continue the pregnancy. She didn't abort completely. Or she had painful threatened abortion. She used to get pain while she used to pass a few clots, a bit of spotting in the first trimester, but she did not abort completely and that pregnancy has progressed. Or apart from that, if there has been some procedure, some invasive procedure like chorionic villus sampling or amniocentesis, if it was done in the second trimester, then there is a chance that she might have had an event of sensitization of feto-maternal hemorrhage. Or if she has sustained an abdominal trauma, maybe in the form of an assault or maybe in the form of an accident when she just fell, she tripped over and she had a trauma to her abdomen when she was in her second trimester and third trimester. So these all events are going to be major events in which a pregnancy continues, but still, I'm not talking about abruption and all those things because you would be terminating the pregnancy then. But the events that I just spoke of are the events in which there has been an event of feto-maternal hemorrhage, but the pregnancy has continued, which is why it is very important that you repeat the ICT at 28 weeks of gestation. I repeat it again. I have two possibilities. I either get a negative report or I get a positive report. If I get a negative report, the best thing that has happened, all I have to now do is give her injection anti-D. Now, injection anti-D is basically an antibody that I'm giving from outside. This antibody has multiple functions, but two of its functions have been well studied. The first one is that this antibody goes and binds to all the fetal cells that might have entered the female circulation, and secondly, it also destroys the few antibodies that might have been formed against those fetal RBCs. These are the two major mechanisms in which injection anti-D works. What is the dose in which I'm going to be giving her this? It is 300 microgram. Or I can also call it as 1500 international units. It is the same thing, just the units are different. Now, this is all I need to do. Now, once I have given this anti-D, I have given her an antibody. So after this point, you need to know that I don't repeat ICT. The reason I don't repeat ICT is that the ICT is now invariably going to be positive after this point. The reason is I have given her an outside antibody, and which is why this ICT is going to be weakly positive. Weakly positive matlab 1:1 se leke 1:4 tak ke titers mein it is going to be positive. So there is no point of doing an ICT after anti-D has been given. Now coming to the worst possible scenario, and that is what if the ICT comes out to be positive at any point. If it comes out to be positive at any point, the management stays the same. A positive ICT is an indication that there is alloimmunization that has occurred. There has been a sensitization event that has occurred. So alloimmunization is there, and now I need to know that what is the amount or what is the concentration of those antibodies. How strong is that alloimmunization that is present in this female? So what I do is I ask the lab which has done the ICT to give me the titers. By titers, in simplistic terms, it is just the strength, the amount of antibodies, the concentration of antibodies that are present in that female's body. I asked them for the ICT titers, and I also asked them to give me a critical titer that their lab has determined. So there is a critical titer that is specific to every lab. Most of the labs consider it to be 1:16, but still you have to ask them ki tum log ka kya hai. So now either assuming it is 1:16, if they are not giving, then you just assume it to be 1:16. It can either be less than 1:16 or it can be more than or equal to 1:16. Less than 1:16 yani it can be something like 1:2, 1:4, 1:8. It is not significant. So it is not significant and the titers are very low. In that scenario, all I'll ask her is repeat ICT titers 4 weekly. So basically I'm just going to repeat it 4 weekly and I'm going to check whether the titers have gone above 1:16. But once and if and when I'm getting a titer of 1:16, I need to know that she has a strong antibody response that has been elicited inside her. She has strong alloimmunization that has occurred in her. Obviously, this can be because of some other antibody, but for all good reasons and for all practical purposes, we are assuming that it is because of fetal hemorrhage and Rh negative pregnancy. So in this scenario, what do I do? Now this is an indicator that the baby, the fetus is at the risk of fetal hemolysis. Why hemolysis? Because these antibodies are going to be IgG and these antibodies are going to cross the placenta and are going to go in the fetus. So now the baby has a possibility, query fetal hemolysis. How do I determine whether this fetus has fetal hemolysis? Obviously, if you are having hemolysis, it is going to lead to anemia. What do? You will be going to a lab nearby and you are going to get your CBC tested. CBC is complete blood count or complete hemogram. But we can't be testing a fetus ka blood that easily. It is not an easy procedure to procure fetus ka blood. So what do? We have another marker to determine fetal anemia and fetal hemolysis. That marker is going to be on Doppler, a test that we call as fetal MCA, peak systolic velocity. So what do we do in this is, once hemolysis has occurred, the total number of RBCs in the blood are going to reduce. Whenever the number of RBCs in blood reduce, the viscosity is going to go down. Now, whenever viscosity goes down, the velocity of that fluid increases. A very parallel example here is going to be between water and Fevicol. There is a slope. I place Fevicol on that slope and I place water on that slope. Obviously, the water has a faster velocity in comparison to the Fevicol. Similarly, in blood that has had hemolysis, in comparison to normal blood, it is going to flow much faster. So, where do I check for this flow of blood? The best vessel that I can do it is fetal middle cerebral artery, and in that we check for the peak systolic velocity. So basically, peak is the highest, systolic is the highest possible velocity that is gathered during the systole of that fetal heart. So we get a certain value. That value is going to differ at every gestation, because at 28 weeks, for example, at 28 weeks of gestation and at 36 weeks of gestation, the size of fetal head is different. The size of fetal MCA is going to be different. The fetal MCA keeps on increasing in diameter, and the moment a diameter is going to increase, the velocity is going to go down. So in this scenario, I have to understand that the value that I'm getting of MCA PSV at 28 weeks, let's say, is going to be different from what is at 32 weeks or 36 weeks. Hence, we get calculators from Fetal Medicine Foundation that you find online, where if you have to enter a value of MCA PSV, you have to enter the gestational weeks, and it gives you a statistical answer in the form of multiples of median. So either you can have multiple of median less than MOM, जिसको हम कहते हैं. So it can be either less than 1, or it can be more than 0.5, or it can be anywhere between these. That is 1 to 1.5 के बीच में. If it is less than 1, then I can be assured that there is no fetal anemia. So I just ask this female to come back after 4 weeks for 4 weekly MCA PSV. I don't test the ICT again, because once I get a titer of 1:16 or more, I have to understand that the baby is now at a risk of fetal hemolysis. All I have to monitor is if it is leading to fetal anemia. So once I get a MOM of less than 1 MOM, 1 MOM less than 1 MOM is basically that the blood is still not that fast enough to show that it has anemia in it or it has significant hemolysis in it. The other side of spectrum is if the value comes to be more than 1.5, then there is a very high risk of fetal anemia. It is very likely that fetal anemia has occurred, and it has occurred to a great extent. What do we do? I'll tell you after this. What if a value comes between 1 to 1.5? Then there might be fetal anemia, but I don't need to worry about it immediately. I don't need to do any invasive testing. All I can do is I can do 1 to 2 weekly MCA PSV. Even 2 weekly works. So that is all I'm going to do. But what if it is coming to be more than 1.5? Now at this point, I need to understand that there is a very high risk of fetal anemia. I need to check the fetal blood. So what do? I do chordocentesis, fetal chordocentesis. Chordocentesis is basically withdrawing blood from the fetal umbilical cord. And why umbilical cord? I intend to say an umbilical cord has 3 vessels. It has 2 arteries and 1 vein. The arteries carry deoxygenated blood from the fetus towards the placenta. So basically the umbilical arteries contain fetal blood. So I'll be drawing blood from the umbilical artery. I'll be drawing that blood and I'll be checking the hematocrit of that fetus. Now hematocrit for a normal adult is somewhere between 40 to 45%. For a pregnant female, for a reproductive pregnant female, it is somewhere between 30 to 35%. Whereas for a fetus, it is 50 to 60%. It is much higher. Hematocrit क्या होता है? Hematocrit is basically the number of RBCs, the number of cells that are present in plasma. So that is the simplest definition of hematocrit. In a few reports, they also write hematocrit as packed cell volume PCV. So I'm going to check the fetal hematocrit from the cord blood sample that I have drawn. The normal value we have already studied has to be between 50 to 60. But if the value is less than 30% or the value is more than 30%, if the value is more than 30%, I will not do anything. I will call her back after 1 week for doing repeat MCA PSV. So I'll be seeing a trend. So after 1 week, I'll call her back because 30 ke agar upar hai, so I can be assured that it is not significant enough to warrant transfusion. But if it is less than 30%, then I need to give her a treatment called as intrauterine transfusion. Basically, I'm going to transfuse blood to the fetus inside the uterus. Just for knowledge sake, if it is less than 15%, it often indicates that there is active hydrops. The incidence of hydrops is very significant, less than 15%. What is hydrops? Hydrops is, in simplistic definition, it is congestive cardiac failure of the fetus. Why does it happen? Because obviously if there is significant anemia, the heart has to overfunction to ensure जो भी बचा कुचा body में RBCs है, blood है, उसको मैं पूरे body में भेज दूँ. So now that the heart is overfunctioning, at some point it is going to get overwhelmed, it is going to get tired, and at that point it will fail. It will go into cardiac failure, and that will lead to all the back pressure changes, which we call as congestive cardiac failure in adults. What does it lead to? It leads to the production of exudation, transudation of fluid in all the spaces. So there is going to be peritoneal collection, which is ascites. There is going to be pleural effusion. There is going to be pericardial effusion. So if there is fluid in any of these two cavities, then we say that the fetus has hydrops. So it mostly occurs when the hematocrit falls below 15%. Now, intrauterine transfusion. What blood do I give and how do I give? In a normal adult, how do I transfuse blood? I just put in an IV line and I just start giving blood transfusion. Similarly, in this fetus, I mentioned that there are 3 vessels. There are 2 umbilical arteries and there is 1 umbilical vein that is going to the fetus. So I'll be giving blood into the umbilical vein so that it goes directly to the fetus. Which blood do I give? The blood has to be O negative. So basically O blood group, negative of Rh antigen, CMV negative. There has to be a test done for cytomegalovirus and it has to be negative. Leukocyte depleted. So basically no WBCs. How do you do it? You just pass it through UV light, ultraviolet light. ultraviolet radiation. So UV depleted, leukocyte depleted, and the hematocrit of that blood has to be preferably around 80%. So it has to be fully packed with RBCs. Plasma come, RBCs zyada. Why? So that it doesn't require frequent transfusions. How do you give it? You have umbilical vein. Umbilical vein mein you have to insert a needle and you have to start giving it. The problem is the umbilical vein might be too small if you are doing it too early. If you are doing it somewhere between 24 to 28 weeks, the umbilical vein may be very small. You may not be able to put an IV line. You may not be put a needle inside it. So what do? Then you can even give peritoneal transfusion. So basically you directly transfuse the blood into the fetal peritoneum जहाँ से ये RBCs absorb हो जाएंगे. But ये सब करते वक्त the baby might just move and the needle might come out. So what do? So occasionally we also give these babies injection vecuronium. It's a muscle relaxant. It's a paralyzing agent technically. So vecuronium can be given intramuscularly in fetal doses. It can be given to it so that the baby doesn't move for the duration of the procedure. Once this is done, I have to check for the target hematocrit. The target is going to be 40 to 50% के बीच में. I cannot achieve 50 to 60% or fluid overload. I don't even want to overload the baby with blood. A usual baby contains somewhere around 150 to 250 ml of blood depending on कितना gestation है. So I do not want to give excessive blood that it leads to cardiac failure because of fluid overload. So I have to achieve a target hematocrit of 40 to 50%. So how do I calculate how much of volume of blood do I have to give to this fetus? So the volume of blood is calculated by a very simple formula. So first of all, I take a factor that is 0.02 and I multiply it by the estimated fetal weight at that point. So कितना भी fetal weight रहे उसमें मैं calculate करूँगा. इससे मुझे एक x value आएगा. कुछ तो एक value आएगा मुझे. ये x को मैं रखता हूँ बाजू में फिलहाल के लिए. After that, I have to see कि मेरा target कितना है. So 40 is my target and what is my current hematocrit? So assuming my current hematocrit is let's say 20. So इसका difference आया 20. So this is basically the difference in target and actual hematocrit. So difference in hematocrit. Now this 20 has to be divided by 10. The value I get here is 2. And now this 2 have to be combined and I have to get 2x. What is this 10 factor? This 10 factor is basically ये जो x volume ml आया था मुझे blood. Each x leads to an increase in the hematocrit by 10%. So basically when I divide this difference by 10, वो मुझे कितने multiplier से multiply करना है x को वो पता चलता है. So 2x. So now let us assume for an example that the effective fetal weight was 1000 gram. So 1000 into 0.02 amounts to x being 20. And यहाँ पे 2 आया है. So 2x is going to be 2 into 20 which is equivalent to 40 ml. So I'll be giving 40 ml of blood to the fetus. A very easy way of calculation. After this point, now I have to understand that now I have given the blood, I have withdrawn the needle. What do I tell the female? I have to tell the female that the hemolysis is still ongoing. The hemolysis is still occurring. I cannot stop that. So for every passing day, with every one day, the hematocrit is going to fall by 1%. So after a week, I'll call her back. I'll do her again fetal MCA PSV and I'll check कि अभी कितना है उसका. And the target MCA PSV now is going to be 1.7, not 1.5. क्योंकि again, as I said, अगर मैंने 1.5 रखा, if I keep the threshold that low, I have to transfuse the baby with more blood and that will lead to cardiac overload. Which is why now after transfusion, the target MOM, जो हमने बात किया था, is going to be 1.7 and not 1.5. That is done. When do I deliver this baby? The baby which has received an intrauterine transfusion has to be delivered at 34 weeks because beyond this point, all these methods of MCA, PSV and all start differing and hence there is a big difference in the values and hence 34 weeks wala baby can survive in an NICU. So obviously steroid cover has to be taken, has to be done and it has to be delivered at 34 weeks. What after delivery? What after delivery? Irrespective of whether this intrauterine transfusion was done or not, the first thing that I do after delivery is check the baby blood group and I check the baby's DCT. DCT is basically उसके अंदर antibodies है कि नहीं. If the DCT is positive, then there was hemolysis. Then I check the fetal, that is neonatal now, hematocrit. And then I consider whether I have to give the baby exchange transfusion. Do I have to give the baby blood transfusion? I decide after that. The baby blood group, if it comes to be negative, then I do nothing. But if it comes to be positive, irrespective of the DCT status, the female has to receive injection NTD again. Fine. Again, the dose is going to be 300 microgram. Now, one last interesting point, you would ask me कि हमने सब देखा, why do I need to test it at 28 weeks? Why can't I be testing it at 24 or 26 weeks? यहाँ पे there is this one interesting point that I want to talk about. ये जो 28 weeks था, ये 28 क्यों मैंने लिया? इसमें 28 में क्या अलग बात है? So the answer lies in the half-life of NTD injection. जो इंजेक्शन एंटीडी है उसका हाफ लाइफ जो होता है दैट इज समवेयर बिटवीन 16 टू 24 डेज. उसको मैं अप्रोक्सीमेटली 20 डेज लेके चलूंगा. नाउ देयर इज एन इजी फॉर्मूला इन फार्माकोलॉजी कि हाउ डू यू कैलकुलेट द नंबर ऑफ डेज और द नंबर ऑफ आवर्स दैट अ ड्रग इज गोइंग टू स्टे इन योर बॉडी. वी जस्ट मल्टीप्लाई टी हाफ बाय 4 और 5. सो अगर मैं 4 या 5 से मल्टीप्लाई करूंगा या फिर 5 से करूंगा, I get 4 into 20 which is approximately 80 to 100 days. So 80 to 100 days मेरे body के अंदर this NTD is going to stay, which is equivalent to 12 to 14 weeks. Now 12 to 14 weeks from 28 weeks is going to take her up to 40 to 42 weeks. Basically the time at which she will be delivered. So basically this NTD is covering the entirety of third trimester where the risk of fetal-maternal hemorrhage is very high. Which is why after 40 weeks are done, body से सब antibodies गायब हो जाएंगे, ये जो NTD है वो चला जाएगा, and that is why even after delivery I have to again give her a dose of NTD because the fetal-maternal hemorrhage that has occurred at delivery does not have that old NTD का injection that has been given to her. Hence I require to give her yet another NTD after birth. So don't think कि मैंने एंटीनेटली दिया है मतलब पोस्टनेटली देने की जरूरत नहीं है, या फिर मैं एंटीनेटली नहीं देता हूँ ओनली पोस्टनेटली देता हूँ. नहीं, द एंटीनेटल 28 वीक्स वाला व्हाट वी कॉल एज RAADP, that is routine antenatal NTD prophylaxis. It is very important because it covers your entirety of third trimester and the fetal-maternal hemorrhage that can occur in it. फाइनली नेक्स्ट प्रेगनेंसी में यू वुड थिंक कि आईसीटी तो पॉजिटिव आएगा क्योंकि एंटीडी दिया है. नहीं, अगेन द नेक्स्ट प्रेगनेंसी इज गोइंग टू अकर आफ्टर अ ईयर, 2 years, 3 years, 4 years समथिंग. बाय द टाइम एंटीडी मस्ट हैव डिसअपीयर्ड फ्रॉम योर बॉडी. सो एंटीडी का काम इतना ही था कि जो फ्रेश आरबीसीज आए हैं, फीटल आरबीसीज इन माय ब्लड, इन द मदर्स ब्लड, आई हैव टू जस्ट डिस्ट्रॉय देम, एंड वंस दैट इज डन, द वर्क ऑफ एंटीडी इज डन, इट कैन डिसअपीयर फ्रॉम द बॉडी, व्हिच इज व्हाई द बॉडी रीसेट्स इटसेल्फ इन द नेक्स्ट प्रेगनेंसी. And hence in the next pregnancy at 12 weeks I do the ICT. If it comes to be positive, it is not because of the injection NTD that was given in a previous pregnancy, but instead because of alloimmunization and the antibodies that the mother had made in the previous pregnancy, which she has retained in her current body, and that is going to be the problem आगे जाके. So that is it about the basic concept of injection NTD and the management of Rh negative pregnancy. I hope you all understood this algorithm, and we shall meet yet again in yet another episode of OBGYnugget. Until then, keep watching Conceptual OBG. This is Dr. Aditya signing off. Thank you.